what goals should be set to sort of better achieve health equity outcomes, across short and long term? How should we be thinking about that?
So I'm happy to answer that. I'm going to just go back for half a second to the point and say, I agree with you. And as simple as it sounds, I think intention always precedes implementation, or a lack of intention precedes implementation, and I think it's an opportunity, but it doesn't mean we sit there and just think for days and months and years. I think there are ways to do it in the short term, as you're saying, but it's incredibly important because I think oftentimes healthcare disparities, which again sits within the broader canopy of health equity and inequity, often is described, in conversation as an unintended consequence. And I have to say that notion to me doesn't sit well in the absence of evaluation, right? And metrics and things that we're doing. It's like, if we set an intention, at least part of that I think can be addressed. That doesn't mean any payment approach is going to be perfect, right? But we should evolve, in my opinion, over time to be directly intending to address inequity or disparities. And then if we learn over time, there are other things that we didn't intend, and then you evolve forward. And that's the spirit of this. So what can happen? And I think we're seeing early examples of it. I think you can begin to identify measures and processes within payment models and payment mechanisms that can better address equity. So for instance, if there's an intention to focus on social determinants, right? But you look and say, well, quality metrics have nothing related to capture or assessment of social risk factors, right?
Yeah.
Nothing related to referrals to community organizations, nothing related to follow through for those referrals, right? Nothing encoded in care management or care coordination programs related to those social needs. Those are doable, right? I mean, they need to be vetted. They need to be thoughtfully designed, but those are doable. Groups are beginning to do that, right? And tying those metrics and performance on those metrics to financial incentives, right? So that's a relatively near-term thing I think that can happen. I mentioned this earlier. I think the other thing is to say, look, we're going to do a lot of programs, but I think it's incumbent on us to then evaluate all those programs, right? I'm always struck by the number of programs that are implemented. And when we evaluate them, we don't ask the equity question. And so we don't know. I mean, in some ways you don't find what you don't look for. And so I don't think it's actually theoretical for provider organizations, for payers, for those partnerships to say, when we're done with this, or at some midpoint, we're going to evaluate it. And when we do, we're going to put that lens on to say what happened to disparities. So I think that's the second kind of short term. Let me just highlight one long term, which is that I think when you think about the outcomes, cost and payment utilization is one, right? We want to contain costs. Quality is another. I think I would like to see longer term ways of encoding equity into that. And the reason I say that is that if we think about areas that are low value care, for example, or things that, we might be doing quote too much of, it turns out when you kind of like unwrap that, sometimes there are inequities there too. And I've shared this in other contexts, but an example would be joint replacement surgery. So getting a knee or hip replaced, an incredibly common procedure. If you talk to a number of people around the country, they'd say, man, this is something that we can probably make more cost conscious. And do we need to be doing that many joint procedures? Are we doing too many? Setting that clinical argument aside, I think what you find if you take an equity lens to it is actually certain groups, including Black and African American individuals, severely underuse those procedures. So if in an overall effort to try to say, well, let's curb the use of joint replacement procedures, right? Because we think certain groups use too much of it. If by doing that, you don't take an equity lens, you may actually be further suppressing what's already underuse, right? Among certain racial groups. And do we want to do that? And so what are the policy things that allow us to avoid that issue?
That's fascinating.